Yeah. Now you look low power, you look, this is a nodular lesion. Whatever it is a well circumscribed nodular lesion. By now we understand that nodularity, how important it is when we are discussing prostate. The presence of lobular architecture and nodularity is present here, right? Now you look at the cells. You look at the cells. These all cells, they are dual. There is dual population of cells, and there is proliferation of basal cells. These are all basal cells. These are acinar cells. These lining cells are acinar cells, and then there is beautiful, very good slide. This is actually very good proliferation of basal cells can be appreciated here. This all are proliferating basal cells. Proliferate. If you will do P63 and Ki67, P63 and high molecular weight keratin in this, it would be diffusely positive for all of these cells, because these are all basal cell, and this is nothing but basal cell hyperplasia, right? Should not be confused with intraductal carcinoma of prostate or cribriform variant, because these are not true cribriforming. See, glands are fused. No punched out spaces like true cribriform is not present here. Again, see, this is pseudo-cribriforming here, right? So there is proliferation of basal cells here. Very good case. We'll look at other areas also to see what here dilatation of glands and looks like atrophy in this part of the slide. What is there in upper portion, we'll also have a look at. Can anyone tell me what is this? This does not look basal cell hyperplasia to me, this lesion. These are fused glands, right? Fused glands, and these are all pseudo-cribriforming, and there is hyperplasia, definite hyperplasia of cells. You remember breast, and you see that atypical duct hyperplasia has this thin connecting rim that is present here. This is not ADH, but just I am drawing comparisons here. See, there's also a thin rim that is connecting it. So this is clear cell or cribriform hyperplasia that is present, along with basal cell hyperplasia in this lesion. This is areas of clear cell hyperplasia that are present, along with BCS. These two are completely benign entities and often coexisting, right? So these are all clear cell cribriform hyperplasia changes. Well circumscribed lesion, not nodular, no cytological atypia. If you will do a P63, it would come positive. Even though patchy, but it will come positive in these cases. Approach is well circumscribed nodular lesion, solid nest or trabeculae within the benign prostate, basophilic dark blue cluster of cells, associated BPH in background. Important is that the margins are usually pushing, not infiltrative. It can show various architectural patterns like we saw: solid, cribriform, trabecular, gland-like spaces, or even pseudo-infiltrative. But cytology, uniform small basaloid cells, scant cytoplasm, round to oval nuclei, like we saw, fine chromatin, not hyperchromatic nuclei, no prominent nucleoli, minimal mitosis, and no significant atypia. Dual cell layer is always appreciable, inner luminal cells and outer basal layers. There would be basement membrane thickening, hyaline globules could be seen occasionally. Important points to note here is that there won't be any necrosis, no comedonecrosis, no marked pleomorphism. If you do a IHC, you will find P63 and high molecular weight cytokeratin diffusely positive. AMACR and PSA might be negative or weak positive, and Ki would be low. To differentiate it from adenocarcinoma, pattern-based approach is always important. There would not be any infiltrative pattern. True infiltration would not be there. Stroma would be non-desmoplastic. AMACR would be negative. Nucleoli would be inconspicuous, and basal cells would be abundant. In adenocarcinoma, there would not be any staining of basal cell layer, and here it would be strongly positive. Another DD here is basal cell carcinoma. In contrast to hyperplasia, is characterized by more confluent growth, more solid growth of cells that are of various sizes and shapes, and there would be presence of necrosis and atypia. Ki67 in these cases would be very high as compared to your basal cell hyperplasia. An important IHC marker that would be positive in basal cell carcinoma that helps differentiate from basal cell hyperplasia in unequivocal cases is BCL2. BCL2 would help it differentiate if you are in confusion, and if there is focal atypia. I mean, there are subtle cytological features, and it is the lesion is not as florid as it is shown in the image. BCL2 IHC would save your day. So this is the differentiating table between basal cell hyperplasia and basal cell carcinoma. All the features that we have discussed are mentioned in this table. Lastly, red flags that it is not BCH. The prominent nucleoli and abundant prominent nucleoli. In every gland you are seeing prominent nucleoli. There is necrosis. The stroma is desmoplastic. And there is absence of basal cell markers. There is perineural invasion. Ki67 is high. These are all not the features of benign lesions. This is something, then this is malignant.